This is Andy Osbaugh from Duke University School of Medicine. In this presentation, we are going to consider an introduction to pneumonia, a very common infection, including its pathophysiology and clinical manifestations. The learning objectives for this lecture are first to recognize the importance of pneumonia by looking at its epidemiology and some complications from this condition. Next, to define what pneumonia is and other types of lower respiratory tract infections. Third, to understand features involved in the pathogenesis of this infection. Next, to define exactly what is known as community-acquired pneumonia as differentiated from other pneumonia syndromes. Also to appreciate the wide clinical spectrum of disease due to lower lung infections. And lastly, to consider complications of this very common infection. So how common is pneumonia? It's been estimated that there are over 5 million cases of pneumonia each year in the United States. It's one of the most important causes of hospitalization, and approximately 20% of patients with pneumonia actually require being hospitalized for the best therapy. Pneumonia is the 6th leading cause of death in the United States, and approximately 10% of patients with pneumonia end up succumbing to their infection. Now, there are many different variations in the rates of disease. More pneumonia happens in the winter months. Men and children are more likely to be affected, as well as older patients. As you can see, the overall rate of pneumonia for someone who's more than 65 years of age is 75 occurrences per 1,000 patients. So in considering infections of the lower respiratory tract and the pleura, first, pneumonia is defined as infection in the lung parenchyma, especially the region involved the alveolar spaces. Now, the word pneumonitis is a more nonspecific term, just indicating inflammation, but doesn't imply the infectious etiology that pneumonia does. Pneumonia can be caused by either bacterial or viral pathogens or other microorganisms as well. As we go up the respiratory tract, infections and inflammation involving the larger bronchi is referred to as bronchitis. Again, this can be either infectious or immune-mediated. And distinct infectious agents can involve the bronchioles in a condition referred to as bronchiolitis. The word empyema describes a purulent accumulation of fluid in the initial potential space surrounding the lungs. And an abscess will refer to the circumscribed collection of pus within the lung parenchyma, a potential complication of pneumonia. So our lungs are exposed to the outside world, and with every breath, microorganisms can potentially enter into this organ. How do we protect ourselves from this microbial challenge? Well, first, the airways are lined with a layer of mucus, and the cilia along the respiratory epithelium move this mucus forward, including any trapped microorganisms. This is an important innate bit of immunity to protect us from invading pathogens. Additionally, once pathogens enter into the lower respiratory tract, they will find an intact epithelial barrier in normal patients, and secreted factors such as secretory IgA, surfactant proteins, and defensins provide another important innate mechanism of immunity against invading pathogens. However, these mechanisms can be overwhelmed, or due to injury or other types of immune compromise, microorganisms can actually cause an infection in the lower airways. So the features that favor colonization include those factors that may disrupt this mucociliary clearance mechanism, such as airway obstruction or other types of anatomic abnormalities as listed here. Also, there are certain patient populations that have ciliary dysfunction, and smoking is an important cause of this, resulting in decreased ability to mobilize infectious agents as they enter into the lungs. Injury or prior infections due to respiratory viruses can disrupt the intact epithelial barrier, predisposing patients to developing pneumonia. Also, different types of inoculation events, such as large volume aspiration due to altered consciousness or debility in patients, or difficulty swallowing, can also increase the patient's risk of developing pneumonia. Microorganisms can also enter into the lungs from the bloodstream during bacteremic events. Also, it's important to remember that the patient's immune function is vitally important in the protection from immunity, and different types of immune suppression can predispose patients to developing pneumonia. The microanatomical site of the infection will also have important clinical implications. For instance, many types of typical bacterial causes of pneumonia will actually induce inflammation within the alveolar spaces themselves. Now, histopathologically, one can see neutrophils and red blood cells now filling this original airspace, resulting in alveolar inflammation. When this is extensive, radiographically, one can see what's referred to as a lobar distribution, or more dense infiltrate of consolidation on chest X-ray. And again, these is a very common pattern for what is referred to as the typical bacterial causes of pneumonia. In addition to the large lobar region of consolidation, the radiographic appearance of this condition can occur in a more patchy distribution, but still with rather dense alveolar patterns of inflammation referred to as bronchopneumonia. In contrast, when the inflammation occurs primarily within the alveolar wall, we often refer to this as an interstitial pattern of inflammation. Often histopathologically, there'll be mononuclear cells as opposed to neutrophils present within the tissue, trying to fight off the infecting invaders. Radiographically, instead of the dense consolidation seen with lobar pneumonia, these more atypical patterns of pneumonitis will have reticular and fine lacy patterns of inflammation. Again, even though there's a great overlap between these syndromes, this has classically been described with viral pathogens as well as the atypical bacterial pathogens listed here that will be discussed later. Community-acquired pneumonia is a lower lung infection that occurs within the pulmonary parenchyma in a patient who is living in the community rather than in a healthcare setting. Historically, there has been an overlapping but somewhat useful distinction between what is called typical and atypical pneumonia syndromes. Now, typical community-acquired pneumonia often includes patients with an acute onset of illness. The infectious agents are often readily identifiable either by culture or by gram stain of expectorated sputum, and such typical agents would include Streptococcus pneumonia or Haemophilus influenza. Also, typical community-acquired pneumonias historically were more responsive to cell wall active antibiotics such as the beta-lactams. In contrast, early clinicians noted an atypical pattern of community-acquired pneumonia, which its presentation sometimes was less acute than that for the typical causes. The causative pathogens were unable to be identified in routine bacterial culture or by gram stain of expectorated sputum, and these pathogens were typically not responsive to penicillins. Our case patient in this module presented with a typical community-acquired pneumonia. Again, he was previously healthy, and he had many of the physical signs and symptoms that one would associate with this acute illness, including fevers, rapid breathing and rapid heart rate, and a productive cough with purulent sputum. Our patient had evidence of hypoxemia with pallor and cyanosis, and on lung exam, a more consolidative and focal pattern of infiltrate would present with dullness to percussion, perhaps decreased breath sounds because of the alveolar inflammation, and various other auscultative signs such as crackles, rhonchi, and egophony. And examples of these are embedded in the file for you to listen to. Other investigations in typical patterns of community-acquired pneumonia may include a chest X-ray showing a lobar pattern of consolidation, as well as an increased white blood cell count on a CBC, perhaps with a left shift showing immature white blood cells. Again, sputum samples, as demonstrated on the right side of this slide, would demonstrate the predominance of neutrophils, as well as perhaps the causative organism by gram stain. In contrast, the atypical community-acquired pneumonia presentation would be more like this patient, a 32-year-old healthy patient who had a more prolonged subacute illness with low-grade fevers, a bit of a sore throat, and an intractable cough rather than excessive purulent sputum production. Although the patient was ill, he was able to continue to work during this time. He noted no sick contacts, recent travel, or any evidence of immune suppression. On physical exam, in contrast to the acutely ill and hypoxemic patients with community-acquired typical and extensive pneumonia syndromes, atypical presentations would often show a more mildly ill-appearing patient with only diffuse changes on lung exams without focal consolidation. This is referred to as a walking pneumonia syndrome, and primary care physicians see this with some regularity and prescribe empiric antibiotics for this condition, often with complete resolution. In addition to the underlying infection of the lung space itself, what are some complications from pneumonia? The underlying inflammation can lead to the exudation of fluid into the pleural space, resulting in a pleural effusion. And depending on the size of this effusion, it can compromise some lung function. If this effusion becomes infected or filled with purulent material, it's known as an empyema, and these often do not resolve on their own and must be drained to result in clinical cure. Again, there's often necrosis and breakdown of the pleural with spread of infection into this area. Long-term complications from this can include adhesions and lung fibrosis. Another very serious complication of pneumonia is the development of a cavity or a lung abscess. This is defined as a circumscribed focus of necrosis within the lung tissue, as can be demonstrated in the CT scan on the right side of the slide. And in this gross image of a lung cavity, you can see the necrotic changes around the wall and filling this space of this lesion in the lung. Oftentimes, lung abscesses are associated with microorganisms that can result in necrotizing inflammation, such as staph and strep species or gram-negative rods, and often this occurs in response to an aspiration event.